what I'd like to do is introduce you to our panelists. Very pleased to have individuals from Eskaton, Livingston Community Health, and Healthy Davis, UC Davis to present. And you will have access to the bio, so I won't go into lengthy descriptions. These are quite outstanding individuals with distinguished careers. Very pleased to have colleague Sheri Peifer, who's the Chief Strategy Officer at Eskaton and has been involved in building out programs, including our Lighthouse program, which is a very unique program reaching older adults in affordable housing. But in this case, how do we reach homebound older adults? And she's joined by her colleague, Darlene Cullivan, who is the Senior Manager of Outreach and Impact at Eskaton, who has been taking the lead in helping bring this program to life, reaching as many individuals as possible in the community. And then we have Helidee Millan-Govea, who is Community Outreach Manager at Livingston Community Health, one of our outstanding community health centers in Merced County in rural California, who has been working on developing this program and is joined by her colleague, Veronica Chavez, Community Outreach Manager at Livingston Community Health. And the two of them will share the unique approaches they've taken, particularly given some of the hesitancy and challenges we've had in the last few months in reaching population, particularly our rural residents in California. And last but not least, Dr. Sheri Belafsky, who is the medical director, not only of Healthy Davis Together, but of the surveillance program at UC Davis, and has been involved in standing up what is a unique program in the state of California and actually the nation, and bringing together government, cities, and a university to reach and help individuals in their community, and now focusing on vaccinations. So with that, I'd like to start our program. Next slide, please. And what we'd like to do is make sure, next slide, that we are able to share with you that all of the programs you're hearing today have been brought forward through the support and mission of our CITRIS Health initiatives that are looking at developing and identifying purposeful, community-led technology solutions to benefit healthcare. We have a specific emphasis on telehealth and digital health, looking at innovations, but in each case, we're looking at developing sustainable and scalable programs to create health equity. The three programs you are hearing today are perfect examples of that. Please, next slide. The programs that you're hearing also represent a deeper approach to addressing COVID. We have been looking at the key problems in this area, and through an anonymous donor, we have been able to stand up three specific initiatives. First being our Lighthouse for Older Adults, which is looking at a way to bring broadband to older adults in affordable housing, and not only looking at the technology, but looking at digital literacy and bringing different types of training to help older adults, particularly in this period where we have had isolation leading to depression, et cetera, and how we can change that, particularly going forward post-COVID. We also have, again, Activate, which is working with Livingston Community Health, and the idea of developing a digital first pathway in terms of how we can support not only clinicians, but reach residents in rural communities who have not had access through internet or telehealth, and to bring them programs. And now to take it one step further to help in this issue of getting vaccinations to as many individuals as possible. And finally, if you go to the next slide, a wonderful program, Healthy Davis Together, which has been a joint program between the City of Davis and UC Davis, University of California, Davis, to address the issues around the spread of COVID-19. And you will hear more from Dr. Belafsky about how they have approached that. But again, bringing together issues in terms of looking at the epidemiology, health promotion issues to address an entire community in this area. So our colleagues will add some elements to that. You will have access, and we appreciate your turning to our website to learn more about these programs. But today we want to focus on this issue that is most critical to helping us all address COVID-19, and that is getting vaccinations to as many people as possible. So with that, we'll start our program. Next slide. It's clear that there are tremendous inequities, not only in terms of how COVID-19 has impacted individuals, but now we see it even more so in terms of vaccination. We do know that COVID-19 has been seen, there's a tremendous disparity in terms of who's admitted to hospitals, morbidity, mortality issues. Again, and that even goes back to the underlying chronic conditions in this area. The data you see there just reinforce the point that the disparities dealt to our society through COVID-19 have just been come forward in many different capacities. So the risk for severe illness, again, not only increases with age, and particularly our older adult population, but because of these other chronic conditions and with other populations within our society. Next slide. And that goes forward in terms of the distribution for vaccinations. Data that you can see that are presented here from the Kaiser Family Foundation reinforce the fact that certain population groups, our white non-Hispanic colleagues who really have benefited from getting vaccinations, are getting a disproportionate share, and that we have to look at ways to reach other populations within our society who are socially vulnerable. So we are seeing issues there, not only with the availability, but then hesitancy. And it is our hope and intent that programs like you'll hear about today will help overcome some of those areas and expand to reaching more individuals and break down some of the barriers in this case. Next slide. Particularly, we have seen a number of different organizations in this area. Those of you who have been tracking this closely may have seen that even shortly, just a few days ago, we saw major efforts to reach now many more individuals in terms of community health centers. Just the other day, there was a federal effort to reach now more than 10 million individuals in terms of providing the vaccine in community health centers. But we have seen delays in getting there, and now we have to make up for time. And again, making sure that we reach all individuals and all populations equally. So looking at equity, the programs you'll hear today are taking some very unique and innovative approaches, as well as fundamental public health approaches to addressing the situation. Next slide. So our first presentation will be from Sheri Peifer and Darlene Cullivan, who again will speak to the program that they have developed at Eskaton and how they have reached particularly homebound older adults who have been disproportionately affected by COVID-19. Sheri and Darlene, the program is yours.
Thank you so much, David. It's a pleasure to be here today. We represent Eskaton, a nonprofit organization in Northern California. You can go to the next slide, please. And Eskaton is a very unique organization. We're probably one of the fullest spectrum of services types of organizations you'll find. We provide home-based services, so non-medical home care, home health care, as well as community outreach services. And then we also provide campus-based services, affordable housing, as David was alluding to earlier. We are a part of the Lighthouse Project, and we also provide independent assisted memory and skilled nursing as well. We have about 2,500 team members as a part of who Eskaton makes up Eskaton. And one of the reasons why we became extremely passionate about this program is obviously we started rolling out vaccines in January or late December actually within our communities. And we quickly learned that it was rare that even our affordable housing communities had access to the vaccine, which we thought if we didn't have amazing community partners such as independent local pharmacies that really came forward to help us, we wouldn't have been able to scale our community-based vaccination program. So when the opportunity arose where we were able to think about how to reach those that cannot come into a community setting or even access vaccine, we thought this is the perfect opportunity to innovate and learn something new. And that's where we'd love to share our lessons with you today. And so I'm going to kick it over to Darlene, and she'll share with you a bit about our mobile vaccination project.
Thank you, Sheri. We were so pleased to have the opportunity to make sure individuals living in their own homes were not overlooked. It's a special part of Eskaton, as Sheri mentioned. We are a nonprofit, and our mission is to enhance the quality of life of older adults through innovative health, housing, and social services. But what makes Eskaton so special is our nonprofit initiative that wants to not only make sure those folks living in our communities are provided with resources to live well, but also to the broader community. And so we have a telephone reassurance program that serves older adults living in their own homes, and several of them do not have access to resources. We became very much aware of that at the beginning of COVID-19. And so, as Sheri said, when the vaccine became available, we really wanted to key in to this special population that we care for. So how we started such a large project was we attempted to reach those living at home, not only the folks that we knew through Eskaton's telephone reassurance program, but also through our partners at Meals on Wheels. We reached out to them and asked about their clients, if we could possibly spread the news to them to provide access. And so the news started spreading. We began telling people through a simple flyer, inviting them to give our Eskaton Resource Navigator a call. And so sure enough, calls started coming in. And not only were they Meals on Wheels clients, they were our telephone reassurance participants. We also reached out to other connections that we had through affordable housing communities. And before we knew it, we had about 400 individuals on our list who were requesting more information about receiving the vaccine. So we were thrilled. As you can see by this very powerful quote from Kitty Torta, a Meals on Wheels client, she says, "I'm stuck at home and have been in a wheelchair for 25 years. It's been impossible for me to get out to get the shot. I'm so thankful for Eskaton and what you're doing." And we realized that we really are hitting this special population in a very special way. How else could they have received this vaccine? So through our partners with Alpha One Medical Services, this medical response team was able to dedicate a mobile unit. Along with Eskaton's home health team, we were able to deploy 2 units. And when we originally started, we thought that Sheri and I thought, well, probably about 40 individuals a day. And then quickly we learned that was way more that could be served, because vaccines have to be in increments of 5 or 6, depending upon the vaccine. And it all has to be in a very timely fashion, plus going to people's homes and the observation time that is required. It took much, much more time. And so 10 individuals to 12 individuals, depending upon the vaccine, were served in one day. So over the course since the beginning of March, we thankfully were able to vaccinate over 200 individuals living in their own home. And we're just so grateful that we had that opportunity. And then we decided, next slide, that not only do we want to reach elders who are living in their own home, but we also want to provide a vast access to people. So we ventured with our partners at Innovative Health, the PACE Center in Sacramento, to bring a drive-through mobile clinic. And so again, with our partner at Pucci's Pharmacy, they were able to provide all the clinical side of vaccine administration. And we, along with Innovage, provided the volunteers to serve 500 folks a day. And so with 4 clinics total, we were able to serve 2,000 individuals. And as this slide said, that did require more robust volunteer crew to serve that many individuals. The individuals were able to stay in their own cars, and that made that extra safe atmosphere for people to receive the vaccine. They were also treated to refreshments and just the knowledge that they were being cared for. And we wanted to do our part in reaching the community and providing opportunities for them to live well by providing the vaccine.
Thank you, Darlene. And next slide, please. So moving on here, the critical component is community partnerships, and that's really the essence of what needs to be in place if you are to roll something out successfully. Eskaton relied upon existing relationships and built new ones very quickly. I call Darlene the logistics coordinator. Even though she's community outreach, she quickly became very savvy at how critical a logistics coordination position is for vaccine management and rollout. Strategic partnerships included, as I mentioned earlier, independent pharmacy in Sacramento, Pucci Pharmacy, which I'll talk about in a minute a little more. But these partners were critical for identifying ways to reach out to people who are in their own homes that are unable to access a site. And one of the things that we learned early on, I would say, is that it's very important to understand the many moving pieces and what I would say, the questions when vaccine, we were rolling this out in March and April. So the vaccine was here 1 week, but then we didn't get a second delivery of vaccine. So you have to be very nimble, and your community partners have to be used to some of these ebbs and flows in the system or process. And what we learned quickly too is that our community partners, such as Alpha One Medical, was able to be very nimble as a paramedic and EMT company. And they are very used to switching on the fly. And so that was very beneficial. We learned a lot at Eskaton in our licensed home healthcare agency, and our nurses were also learning how to be nimble and flexible as we were rolling this out. One of the things that we all know is Meals on Wheels programs are available throughout many of our counties, and that is certainly one area in which you want to do outreach. And we were so thankful to have ACC, which is Asian Community Center. They manage the Meals on Wheels program here in Sacramento, and they were so quick to step up and say, we want to be a part of this. We have people that are in need. And they worked very well in getting information out to their clients. And as Darlene said, we thought we could do 40 in a day at least. At Eskaton, we were doing hundreds in a day at our community settings. So we thought, how difficult could this be? And we learned that it is a process, and it's a long process. And we're still involved in doing our mobile vaccine because we still have people on our list. So next slide, please. As I mentioned, Meals on Wheels, Pucci's Pharmacy, Alpha One Medical. These were our critical partners that made this happen. Of course, our Eskaton licensed home healthcare as well. And it's so meaningful if you can develop those relationships ahead of time, over time. Pucci's Pharmacy, I just want to pull them out because that's one of the most innovative independent pharmacies I've been able to learn about. And they were just wonderful in stepping up, and there were a lot of questions, and they were able to fill the gaps and help us gain access to the vaccine as needed, and continue to do so. So again, a successful program requires these relationships to be in place. Next slide. Darlene, would you like to share a little bit about lessons learned?
So
since we have a lot.
We did learn a lot of lessons day by day, and we continue to learn lessons. But here are some of the key lessons. We understood that coordinating the distribution of vaccines requires a lot of creativity. As mentioned before, each vial contains 5 or 6 doses of vaccines. So delivery routes have to be in multiples of 5 or 6. And so, like I said, we did 10 to 12 individuals a day. And also, we were just so grateful that the local pharmacy, they had to evaluate the logistics of protecting the vaccine during the distribution. So maintaining proper temperature through specific refrigeration systems, as well as data loggers that kept time to make sure that the vaccine was not out of range as far as the time goes. Also, that remote gathering of patient information needs to be addressed on the front end. And so basically that meant we had to take care of registration using our telephone reassurance program and our resource navigator, who literally was on the phone daily for several weeks, coordinating the registration of the route. And then delivering one-on-one services is time intensive. Very, very true. Things that we thought could be really snappy and efficient, we had to slow down and breathe and make sure that we were really meeting the needs of our older adults living in their homes that had unique challenges and unique situations. So again, we had to be very creative, but also very time sensitive. We also wanted to work as quickly as possible. And so we also had to have a layer of empathy, understanding that many patients were afraid and hesitant. And we understood we had to keep educating, and educating. The more information we were able to share and provide, the greater the assurance was. And then also, it did take time after the vaccine. The observation period of 15 to 30 minutes often would even be longer than that, just to give that special one-on-one service that we so much desired to do.
Thank you, Darlene.
You bet.
And I definitely want to give, next slide, please. I want to give my colleagues time to share their stories, which are wonderful lessons for all of us. But some next steps for us, Eskaton, we are looking to become a licensed vaccination provider on our home health side. We have our application in, and it's kind of in a backlog of applications, but we would love to become a licensed provider ourselves. And then also understanding that as Darlene mentioned, there are people who are kind of digital natives, and they have smartphones and they know how to access, how to register. And then there's many people who do not. So having a resource navigator able to help and assist in that online registration is critical. Looking at availability of translated outreach materials. This again, that we're learning in our Lighthouse project for affordable housing communities. We're serving people up to 12 different languages at one time. And so we need to be sensitive to that and able to provide appropriate educational and outreach materials. There were people who decided, they signed up and then they were afraid to get the vaccination and pulled out. So we still have a lot of work to do to build trust and appropriate culturally sensitive materials to move forward. And then also, as I mentioned throughout all of this, is building those relationships, new ones, knowing each other's strengths, how to build upon those strengths to meet the very focused need in our community of older adults. So thank you so much. With that, I'll move it on to our colleagues.
Well, thank you, Sheri. And this is David again, and I will now, given time, we would like to move on to our colleagues at Livingston Community Health. But while we're doing so, before we tee their program up and their presentations, let me first thank Sheri and Darlene for that superb overview and the creative ways you have been dealing with issues related to finding how we can reach older adults in their homes, and particularly the individuals who are hardest to reach. Wonderful lessons learned. We will continue to pick those up. I would like to again offer to our listeners to submit questions so we can do that. But given the amount of time we have right now, we'd like to next turn to Helidee Millan-Govea and Veronica Chavez, who will share with us issues on how they have addressed at Livingston Community Health reaching individuals in rural communities. Again, looking for individuals who've been very much disproportionately have not had access to the vaccine and have a number of social, cultural, even language issues, as we've just heard from our colleagues at Eskaton, in terms of barriers to getting it. So without further ado, we'll turn the program over to Helidee and Veronica.
Thank you so much for that introduction. My name is Veronica Chavez, and I'm with Livingston Community Health, and I'm one of the community outreach managers here. Next slide, please. Livingston Community Health is a nonprofit community-owned health center providing comprehensive primary and preventative healthcare services to all patients, regardless of their ability to pay. We address access to care during the COVID-19 pandemic through vaccination efforts, expanded telehealth consultations, and culturally appropriate resources. We consist of a care team that includes nurses, medical assistants, referral specialists, care coordinators, and providers who are all working to ensure that patients get the care they need. We currently have 7 locations. We have a Hillmore location, Delhi location, Waterford location, Sherlock location, Houston location, and our main campus, Livingston Health Campus. And we have the first school-based health center located here in Livingston, and that is our Wolves Wellness Center. Next slide, please.
Thank you, Veronica. We launched, I'll be going over our project, our mobile unit project, which we deployed last month in April. This project was launched to create a mobile care team that would be able to provide vaccine outreach and administration, testing, follow-up care, and general COVID-19 public health guidance to the population. It was launched, again, like I said, here in the Central Valley community, which has high numbers of immigrants, racial and ethnic minorities, and agricultural workers, as well as high rates of COVID-19 and insufficient access to vaccines and testing. Our goal is really to reach out to those community members that are left outside of the traditional system of the healthcare, for example, agricultural workers. So we'll be going over some of our lessons learned and our next steps. Next slide, please.
Here at Livingston Community Health, in regards to our mobile vaccination project, our focus is to help migrant populations and agricultural workers. We started by reaching out to one migrant camp and others followed. We continued our outreach to existing contacts and employers. First mobile event was back on April 12th at a dairy processing plant. And the following day on April 13th, we had everything set up, our event, logistics, everything went well. But there was a low turnout due to the Johnson & Johnson recall the following morning. We continue to be on track, working with family migrant camps to bring vaccines to tenants. Since April, we have vaccinated around 120 people across 3 sites. So we do have our COVID-19 vaccination clinics at 3 of our locations, and that is our Livingston Health Campus, our Turlock location, and our Houston location. And at the moment, it seems for obvious reasons that Pfizer continues to be the preferred vaccine at the moment. Next slide, please.
This is a setup that we utilize when we have our mobile vaccination events. It really depends based on the size of the event. If it's 40 to 50 people that we're targeting, or if it's over 100 people, for the most part, we have 2 registration individuals that help us with registering people, taking their insurance, their ID, with the completion of the form. We want to make sure that we're making this easy for the community. So I know that one of the barriers that we notice is that individuals, particularly with the Hispanic community, they do not feel comfortable completing any forms. So we do have staff available that can help them with explaining the forms that they're filling out, consent to receive the vaccine, so they feel more at ease. So we try to make the process as smooth as possible. Like we said, and a lot of these individuals are vaccine hesitant, and so we're trying to make it easy access for them to receive the vaccine, which hoping, then they will be more likely to receive the vaccine. We, in addition to the front office staff, we also have the LVNs, the nurses, the medical assistants that are very important in this process. They not only because they administer the vaccine, but because they also provide information to individuals that have a lot of questions on the vaccine. If we have more than 100 people attending, then we try to double our staffing levels. But for the most part, we have been able to deploy a mobile unit with about 5 to 6 individuals. And we have been going out to the various migrant family camps here in the Central Valley. Next slide, please.
Here on the slides, you can see a little bit of our mobile vaccination location setup. So what we'd like to do is we'd like to have everything that you would use in a regular office setting. Registration forms, just in case our system goes down as a backup. We do collect health insurance at the time of the appointment. Materials, we like to have 2 cell phones for our mobile units, a mini fridge to carry all the vaccines, an electric generator, just in case something goes down. And we are lucky to have an IT department to help us with setting up the front office staff to laptops, just to make sure we're able to capture all the information and put it into our system. We like to have cones to separate everyone 6 feet apart, canopies with sidewalls for HIP, just to make sure that, you know, people are receiving their vaccine and they're in a secured spot and they feel comfortable when they're pulling down their shirt for their vaccine. Cots, like Helidee mentioned, we do have a first aid area. So we want to make sure that we have cots there. We have oxygen tanks. We have an AED machine. We have wedge pillows, everything needed for that, for our first aid station. It takes about 30 minutes to load all of the equipment into the mobile units and 15 minutes to unload after every event. All of our materials have been placed in labeled totes per station for easy carrying, loading, and unloading. So every station will have one of those totes you see on one of the slides. With the registration goes under the registration table, first aid goes under the first aid table, and so on and so forth. Next slide.
One of the main takeaways, and I would say lessons learned for us, has been that education is critical when we're trying to decrease barriers to vaccination. So again, we have been particularly working at the moment with the migrant camps, and we do experience, or we come across a high number of individuals, a majority the older, that are very hesitant to receiving the vaccine. So we try to provide as much information as we can. So one thing that I will share with you that has worked for us is, prior to having the vaccination event, we do meet with them, and we do sort of a education piece, which is one-on-one with them. So we, for the migrant camps, we went door to door and we spoke with them regarding the vaccine. We listened to what they had to say about what they were worried about, and then we provided, you know, the resources, the information that we know on the vaccine. So our goal is to listen to their hesitancy and then provide the information, and at the end of the day, provide them the tools, the access to the vaccine. And like I said, we make it very easy because we're literally bringing it to them at the place where they live. And then we let them decide at the end of the day if if this is something that they want to do. So again, we are really addressing patient education. So we always communicate as well that there will be a nurse on site at the day of the event that can also answer any questions that they may have. I know we had an individual at the last event that we had last Monday that was very hesitant about getting the vaccine when we went to do the pre-registration, and we answered as many questions as we could, and then we invited her to go and talk to the nurse, and the nurse answered all the questions that this individual had, and at the end of the day, she ended up getting the vaccine. And she said, because you guys are already here and you guys are making it so easy for me, I'm willing to take this step. So again, many individuals do share with us that they are not interested, and our goal is not to pressure anyone on getting the vaccine. We are just providing the resource, the access, the information, and at the end of the day, it is their choice. Next slide, please.
Like Helidee mentioned, education is critical for decreasing barriers to vaccination. Language barriers, we can serve as a barrier to traditional outreach. All LCH employees are bilingual, and all of our outreach materials are created in Spanish and English. Here to the right, you will see the flyer that we have been using for migrant camps. Super easy, straight to the point, how to add their name to the list. They go to their manager and they tell them that they're interested in the vaccine. The day of the vaccine, the day of their visit, what they need to bring to their appointment. We ask them to bring obviously their health insurance card and an ID to enter them into our system. We tell them they're receiving the Pfizer vaccine. We schedule their first dose. from between 4 and 7. There's no appointments, just come in during those times. And their second dose is scheduled at the time that they receive their first vaccine, making it even easier for them. If they have any questions, Helidee and myself provide our direct line. We do have a work phone, so we provide our cell phone just in case they have any questions. Here in our organization, everybody knows that we're the ones handling the mobile unit, so all of the phone calls come through us. So there's no challenges for any of our patients trying to get in for any vaccinations. All of our materials on our social media page are also in Spanish and English, and we do have other languages that we speak here at our health center, which is Punjabi and Portuguese. Next slide, please.
So one of some of the frequently asked questions that we get asked often is what type of vaccine are we providing? So again, this is all part of the education piece. One thing that we do when we go to complete the pre-registration, we do get a sense for which vaccine community members prefer. We're not going to be bringing Johnson & Johnson if it's not the vaccine that they feel more safe with. So for the most part, like we mentioned, it has been Pfizer. So we explain which vaccine it is, and then another question that they ask is how many doses. So this is something very simple, maybe for us as healthcare providers. Maybe it's something that we take for granted. We think that everyone knows the Moderna and Pfizer are 2 doses, and the Johnson & Johnson is only 1. Believe it or not, we come across a number of individuals that they're not sure what is the difference between the vaccines, which adds up to their hesitancy. How safe is the vaccine? Again, we provide resources and we get them from the CDC website as well in their language. And they also ask us about our experience. So this is very interesting because once we tell them our experience with receiving the vaccine, then their perspective changes as well. Next slide, please.
Lessons learned through the mobile vaccination program. We have learned that education is critical when we're communicating about the vaccine, like Helidee mentioned, addressing, their questions. When do they receive their second dose? If they're hesitant about receiving their vaccine. We also mentioned that we are going to be bringing an LVN on board, if just in case they're hesitant, they can get some information before they get vaccinated. There's flexible timing of location and availability needed to reach all potential patients. When reaching out to employers, we have experienced a lot of challenges and barriers because due to COVID and all the restrictions around COVID, we're only allowed to talk to their HR office. So it's very difficult for us to capture companies that employ 500 employees, 300 employees, because we're only allowed into the HR department and whatever HR is willing to post. So many plants have 30-minute breaks, which makes it kind of difficult for them to get a vaccine, as there's a 15-minute wait period after they're vaccinated. So employees don't have time to get the vaccine, and often information that's posted in the break rooms is missed. So meeting patient preference on type of vaccine is essential to reducing hesitation. LCH has expanded vaccine options to meet patient preferences. Like we mentioned, the majority prefer Pfizer. And then all services that we offer are culturally appropriate and we meet all language needs. Recently, we just hired a new CHRS, which is a community health resource specialist, and she's in Punjabi, and we will be focusing here in our Livingston area, which majority of our patient population is either Hispanic or Punjabi. So we have added this new hire, and we're sure she's going to be an asset to the team as we're trying to get into this population. It's very difficult for us to go and try to reach out to a population that we don't speak their language and they don't speak our language. So having somebody that speaks their language and understands their needs will make it a lot easier for us to work with the population. Next slide, please.
Okay, and to conclude, we just want to share with you our next steps. So as Veronica mentioned, we will continue working with not just we've been working a lot with the Hispanic population, but we will be working with the Punjabi population here in Livingston and surrounding areas. We will also be working with the partnerships. Again, someone mentioned before the importance of partnerships and relationships. We have good partnerships and relationships with other organizations here in the area, and therefore we will be having an event, a mobile vaccination event, actually next week at one of the local districts here nearby, so that we can target 12 and older. So we will continue working with 12 and older and continue with the deployment of our mobile unit. So these are our next steps. And like I said, we just want to make sure that when we're reaching out, we're being culturally sensitive, where all of our flyers are in English and Spanish or, Punjabi for our events. So this will be our next steps. And like I said, the one main thing that I would say the takeaway is, if we really want to reduce vaccine hesitancy, we need to be able to provide information, accurate information, and we need to provide easy access for those individuals that are ready to take that step. Next, thank you. Next slide.
Thank you very much, Veronica and Helidee. And that was a perfect set of examples and recommendations in terms of not only lessons learned, but some very innovative approaches. And I think both presentations that you've heard so far clearly have shown how one has to be nimble, innovative, really reach to the population that one is working with, and look for partnerships to have the greatest impact. We did have one question that it would be timely to answer before we turn to our final panelist, and that would be for our Livingston colleagues. How did you determine vaccine preference? You mentioned that Pfizer was preference for a number of the individuals who've received the vaccine in your clinics in these special outreach programs. But what was it? How was that determined? Could you add a little more information to that? Because I think we'll see more and more of that issue in terms of whether it's hesitancy or just getting different vaccines to populations. So could you please share some guidance or how that was determined in terms of identifying preference?
Yes. So for Health Center, we do offer all three of them. We do carry Johnson & Johnson, Moderna, and Pfizer. But for migrant camps, Helidee and myself do to the door-to-door approach. So we do outreach. So whatever location we are planning to vaccinate, for example, a migrant camp, they have 73 units. Helidee and myself will knock at those 73 units and we will ask them, which one would you prefer? So once we get a final count of how many people have pre-registered, we come back to our organization and say, out of the 73, 70 preferred Pfizer. So that's the one we take. The other three, if they prefer Moderna or Johnson & Johnson, we do schedule them here at our location, and it's nearby. So we have 7 sites. So it's easy for us to help accommodate those appointments here at our health center. But it's actually the pre-registration piece is key, as well as, listening to whatever our migrant families are in need. And now that Pfizer is available for 12 and older, it made it even easier for them to say, I want my children also vaccinated.
Excellent. Well, thank you very much for sharing that. And again, we can delve into that more as we get into our full Q&A at the end of the panel presentations. But given our time, I would like to turn the next presentation over to Dr. Belafsky, who has been leading our colleagues through UC Davis School of Medicine and the team at University of California, Davis in creating Healthy Davis Together. As you know, she has a number of other responsibilities, but has led the charge in terms of a unique approach in this area for bringing together an entire community. And now, how has the vaccination issues and the challenges to that been addressed in this community? So without further ado, we'll turn the program over to Dr. Belafsky.
Thank you, David. And thank you to the other panelists. I feel like I've been learning a lot by listening to you all this morning. Next slide, please. This is just a overview of what Healthy Davis Together has been up to during the past 8 months or so. As David already mentioned, it's a joint effort that combines UC Davis, the County of Yolo, City of Davis, and was really designed to mitigate the effects of COVID and to help bring the community back to normal functioning as quickly as possible. Initially, our focus was on the city of Davis, where we were providing regular free testing and also promoting healthy behaviors. And our last piece was really to focus on our local businesses as well, where we were trying to protect employees and customers. Most recently, we began focusing on vaccines probably in February. Next slide. A little bit about Yolo County, where Davis is located. We are just under 250,000 residents with an agricultural focus. Most of our residents do live in the major cities in the county. We wanted to get a sense of what were some of the attitudes and beliefs about vaccine. Back in February, we conducted a survey, and it was, I would say, interesting to note that there were, I would say there was a far majority of our residents who said that they believed vaccines were safe. But when you look at the scale of do they strongly believe that, only about half said they thought they were safe and effective. And then of those respondents back in February who were not yet vaccinated, 61% of them said that they were very likely to go ahead and proceed and get vaccinated. It won't surprise you the reasons for those who did not suspect they were going to get vaccinated. Those reasons will be familiar to most of you, in that it was concerns about safety. Next slide. So when Helidee Davis together thought about what was our driver, what was our interest in participating in the vaccine effort, it was really equity. That was our motivation. That we could see it very early on as the doses were being rolled out. We could see that private healthcare entities were receiving doses, and they were able to go ahead and vaccinate their insured patients. And then what we saw on the county level was mass vaccination efforts that were geared towards vaccinating whoever was eligible in that particular tier. Helidee Davis together decided we wanted to focus on the underserved residents of Yolo County. And we made that our focus. And we used two things. And I think that partnership is a term that you've heard from my fellow panelists several times. And that is a key for how we have been achieving this. And then the other is through outreach methods. And I would say we have done a combination of traditional and some more novel approaches to outreach. What you'll see on the slide is just some example of more traditional outreach methods, and also done in a variety of different languages. In Yolo County, I would say that we have a majority of English, Spanish, and Russian speakers. So our literature has been translated into those languages as well as Farsi. And so these are some traditional graphics that we would share. And these are really geared towards people who are interested in vaccine and just needed more information about how to go ahead and get their vaccine. Next slide. So I'll take you through our partnerships first, and then walk us through the some of the approaches that we've used. So CommuniCare is a federally qualified health center, and probably the provides care to the largest number of uninsured and Medi-Cal patients in Yolo County, with about 35,000 patients. So we decided to partner with them. And what we did was open two fixed site clinics based on California's Healthy Places Index population. So based on lowest quartile, we chose the city of West Sacramento, and we chose Woodland. And in those two areas, we are serving patients 5 days a week. Our other partner is Yolo County Health and Human Services. And our role with Yolo County has been to provide mobile vaccinators. And we have supported their farm working mobile efforts, where we would send a team of vaccinators out to a particular farm where the county had already established a partnership with that with the owner of that farm and coordinated a day when farmers would come on site. So to that end, about 83% of Yolo County farm workers have already been vaccinated. Our other mobile efforts in coordination with Yolo County was long-term care facilities, where there's a lot of turnover of both staff and residents. So it requires, I would say, like a high touch effort there. And that's obviously not a very mobile population. And then as you all are quite aware, the staff at long-term care facilities was very much impacted, and it was not easy for them to go off-site during their off hours, say, to get a vaccine. So there were a lot of good reasons to go on site for those folks. And finally, we also were doing some mobile work with the county for those who are unsheltered. Next slide. So over my next couple of slides, I'll show you some of the approaches that we've used. And this is kind of fun for me to get to say that a novel approach is the telephone. So most of us wouldn't really think of that as a novel outreach approach. However, in this iteration of scheduling COVID vaccine appointments, so many of them are done, or the expectation is that they'll be able to be done online. We noticed and heard directly from our community care partners that most of their patients would not have great access to the internet. So what we did was set up a dedicated call center. So most of their patients could receive a brief text message. So community care pushed out 40,000 text messages in the first, I guess, in 3 months or 2.5 months that we've been operating. And our call center, I'll back up. They pushed out 40,000 text messages that was alerting their patients when they became eligible, and also provided our call center number. And we carefully guarded that call center number, really reserving it just for community care patients, because we wanted to prioritize those who really needed that special handhold. So we were able to schedule 4,400 appointments in the first 2 months. We had something like a 99% scheduling rate for inbound calls. So that, I would say, was a very effective strategy. I will say that it was also quite a resource intensive, in that there were 15,000 outbound calls that did not yield appointments. So about 20,000 plus calls made in just those first 2.5 months. And then lastly, what was also special about our call center, but probably not unique, as I'm hearing from my colleagues, that we wanted to address that many of our patients would be speaking different languages. So we hired staff that were bilingual in Russian and Spanish. And then to address those who were speaking a different language, we also set up a language line interpreting service so that we could assist those patients as well. Next slide. To address transportation barriers that some of our patients faced, we also partnered with CITRIS Health as well as Community Care to be able to send Uber rides for those patients who otherwise could not get a ride from a friend or a family member, or couldn't make it to those centrally located vaccine clinics that we have. Next slide. I would say that one of our key approaches has also been to be flexible about our clinic operating hours. We learned very quickly from our community care partners, from their providers, and then from direct feedback from our call center, as well as a patient survey, that for essential workers to make it in to vaccine appointments, we needed to provide evening hours as well as Saturdays. So we flexed and changed our operating hours for our clinics to do that. Also, how we're addressing some of the natural lulls that we experience by having a vaccine clinic that's open throughout the day is by flexing our staff. And during those quiet times, we have them make outreach calls, either call patients who have missed appointments. And then in some of our, I would say, more novel approaches, we've actually sent teams out in the neighborhood to do direct outreach to local businesses, let them know that our clinic was open and that they were eligible, and to sign people up for vaccine appointments right there on the spot. Finally, in 2 weeks ago, we were able to add another convenience, which has been really appreciated by our patients as well, which is the ability to do walk-in appointments. Next slide. Where we are now, so I'll kind of bring you up to the moment. We continue to have our 2 fixed sites that are open in West Sacramento and in Woodland. And then in addition to that, we are increasing our mobile outreach efforts. And we're doing this in partnership, in addition to CommuniCare, with other community-based organizations in Yolo County. And we're really relying on the knowledge of our local experts, particularly in West Sacramento, where there's been traditionally, I would say, predating COVID, there has been a very low vaccine uptake rate in pockets of the West Sacramento community. So some of these approaches, in partnership with the Yolo County Homeless Coordinator, we sent out a mobile team with a portable fridge to go door to door at a series of motels in West Sacramento over the past 3 weeks. And this population is, I would say, intermittently unsheltered, and they are very much well known to the county's homeless coordinator. And that yielded 50 vaccines so far. And then what we have planned, again, under the guidance of our partners, community-based organizations in West Sacramento, are some events that are geared towards families that have a less transactional nature, where we're hoping to be providing information in a very family-friendly environment. So those are going to be scheduled for neighborhood parks, and there will be music and food. And that's coming up in about 2 weeks. We'll have our first one. And then we have, as the 12-year-olds became eligible just last week for Pfizer doses, we partnered with the Washington Unified School District, again, West Sacramento, you're hearing this theme. And we have 3 schools that we are doing pop-up clinics at, 2 this week and 1 next week. And we will continue to provide vaccines for not just students, but also staff as well as family members. Finally, with another partnered community-based organization who does food distribution on a weekly basis, we're sending out our clinical team. I don't know if donuts are considered novel, but when they drive up for their food distribution or food pickup, we're having clinical staff as well as a local promotoro that we're working with walk car to car and hand out donuts, but also ask if people have any questions about vaccines that they can answer. Next slide. So where we are thus far, in about 2.5 months, we have administered over 8,000 doses. We're excited to report that about half of those doses have gone to recipients who identify themselves as Latinx. And then a kind of a bigger snapshot of where's the county. 61% of eligible residents have had at least their first dose. So that's where we are at the moment. Next slide. And just a shout out to some of our fantastic partners in the county. Thank you so much.
Well, thank you, Sheri. And again, thank you to all 3 panels for what we have learned. We have assembled a few items just to share with you in terms of the types of lessons learned. You have seen from each of them some very unique areas, but it's very clear that a few things really stand out. Certainly, community partnerships. We heard that from whether you're in a rural community, a suburban, whatever type of community. It's not the only to a single organization that can have the greatest success here, but we see the wonderful examples today of how different types of partnerships, whether it's with other providers, whether it's other community groups, whether it's with private sector, how you can best bring this together. Second, patient education, and we'll want to ask our panelists a little bit more about this in terms of how individuals are informed about what are the benefits of vaccination are and how they've been able to overcome different types of hesitancy issues. So again, that whole area around patient education. But we also have heard culture and language again and again. And we've seen this not only in Lighthouse and Activate over the years, the last year, and Healthy Davis Together, how we have diverse communities and how you have to adjust. But how do we then address that? And we'd like to come back to once again reinforce that in our discussion that we'll go into shortly. And finally, an issue around where we're looking at how you not only can do very strategic planning, look ahead and identify opportunities and the best way to approach this, but also how to be flexible, customize, be responsive in the immediacy. I would like to make sure that we also hear one other thing before we go on, and that is that we've seen solutions that are both taking the vaccine to individuals with mobile solutions, as well as those that are based in certain clinics and inviting people to come to where vaccinations can be provided in even greater quantity. So we're seeing some wonderful approaches here. And now I'd like to start turning, if we could do the next slide, please. We'd like to open this up in the next 15 minutes for questions from you and some common ones that I'd like to pose to our panelists, and also let them ask each other specific areas and items that have come forward from this approach. Again, 3 different communities, different approaches, different populations, but each with some very innovative programs and some similar approaches to how they've tackled this very important area. We'd like to wrap up with allowing each of our presenters to offer one takeaway for today and before we close for the session. So with that, I would like to pose a first question to all of our panelists. And in terms of the communication strategies, you've all mentioned ways to address it through language, cultural sensitivity, but what would you say are the fundamental points in terms of how you've communicated? Is there any specific element that has been most important as you've reached different populations through and addressed these different language and cultural issues? Communication, education, as we said, is a common takeaway. Would anybody like to say what they think would be, for anybody who's looking at this for the first time, be the key issue to consider from the outset in terms of communicating with the individuals you're trying to reach for vaccinations? Dr. Belafsky, we'll let you start, please.
Yeah, I would say that it seems essential to build relationship and build trust. I think may have been Veronica who had shared that. That's also her experience. We've also are doing work in Yolo County migrant camps as well for farm workers, and we've been learning the hard way that we can't go out, whether it's for testing or vaccines, and expect that people will trust us or want to participate. So we're noticing that it takes a number of visits where we're just really meeting people and introducing ourselves and being available to answer questions first.
Thank you very much. And our colleagues from Livingston, Helidee or Veronica, would you care to add to that, please?
Yes, David, thank you. I think the other thing that I will add is when it comes to communication, our approach has always been when we are speaking with individuals, we like to first really listen to what they have to say, and not take so much of an approach where you approach the patient or the community member and you want to force them or tell them to get the vaccine. Instead, we like to first, like I said, listen to their concerns, because there's always something behind, whether if it's misinformation, sometimes it's a cultural thing as well. I know that, for example, with the Hispanic community, there's a lot of them that do not really believe in vaccination. So we like to first open it up with making it safe, like, okay, tell us what do you think? And then after that, then we go and tell them what we know about the vaccine, and providing information and quoting like the CDC and explaining it, of course, in their language. So I think that's the one thing that I will add.
Wonderful. And before we go on, could I ask you and Veronica, we had one question from the audience that is very critical, and that is there's other resistance issues on the concern possibly for individuals who are undocumented and how they get access to programs. Could you elaborate a bit more for all of our listeners on ways to address those issues and how you are approaching it?
Yes, so our experience here at Livingston Community Health with our undocumented population is, one, they're very fearful about sharing any information. And I think making it very easy for them to understand that here at Livingston Community Health and other organizations that partnered with us, the vaccine is free. So they think because I don't have insurance, I can't get it. Because I don't have documents to present at the time of the vaccine, I'm not going to be able to get it. So I think the educational piece, informing them of, there's programs out there that we can help you with. I know this is around the vaccine program, but we also help with insurance. We enroll them into Medi-Cal, emergency Medi-Cal. So having that connection at the time of telling them, that not necessarily is it something that you cannot get. It's lack of information, and sometimes they just don't want it because they feel that their information is going to be put out, and they don't want that. They're fearful. So we have to tell them, this is a health center. We don't share your information with anyone. Even if you were to apply for Medi-Cal, we don't share your information with anyone. So making it super easy for them to receive the information, make sure the information is clear and the information is correct. It kind of motivates them to come and get the vaccine. And it's very hard to capture them because when us dealing with these migrant camps, they're only here for 6 months and then they leave to Mexico and then we miss them. So we have to make sure that when we do have those conversations with them, we're able to capture all of their information and explain the process of the vaccine. Whether make it super easy. So I think with their mobile unit, that's what we have been doing. They walk out of there with the second appointment to make sure that they're getting vaccinated. We are working after hours, where all of our events at the migrant camps are from 4 to 7. So we make sure that they're, it's even after they're off work. And some of them have told us, can you wait for us? I'm going to get off at 7. Can you wait for us 15 minutes? So we've stayed over just to capture them. So the efforts are being there. The efforts are there. So we continue to work with our population that is very vulnerable, especially in these rural areas. So we do have a lot of undocumented population that we currently work with. So it's easier to, have that conversation with them as we have developed a relationship with them. So I think it's everything that relates to trust and them being open with you and you being able to, link them to a resource. So I think that's what's important, and that's what's going to get them to get vaccinated.
Thank you, Veronica. That was extraordinarily helpful to elaborate on all the ways that one has to be thoughtful for individuals. I think this carries through for anybody in terms of concerns about the impact of the vaccine, much less privacy, et cetera. Like to ask all of you one issue in terms of going forward, and Darlene, we could start with you if you don't mind, and that would be what the key barriers that you still see out there. You've all been so creative, not only getting partnerships, looking at being flexible, customizing your programs, taking it to the individuals and basing it around their own needs as opposed to you as a provider. What do you see as the fundamental next barrier that we have to overcome in your program or in general, in terms of still reaching the next group of individuals that we have to reach to get vaccines to as many people as possible? So Darlene, you may have some experience from Eskaton, but what would you put forward as what is the next barrier we all have to tackle?
I don't know if there are barriers, David, other than what has already been mentioned as far as what we've seen. I think we need to be super creative and intentional with building relationships with other organizations that serve elders within our community. I love the fact that Dr. Sheri said they had the outreach to the motels. I love the fact that Dr. Sheri had the outreach in parks that were more of a community celebration that included food. Those types of things I think are really important, that I'd like to look at possibly expanding our efforts in modeling those, along with the language sensitivity and along with building trust. Other than that, I don't see the barriers. I feel like there's so many opportunities, and this is the time to really show we care and we understand.
Yeah, that's a perfect way to frame it. So whether it's barriers or strategies, please, Sheri, why don't you pick up on that? What you see are those next steps. Hopefully we've tackled many of the barriers, as Darlene so nicely said, through this creative approach. But what would you see next? Either some of those issues that still maybe we need to tackle, or the additional strategy you think we should still try to approach? Sheri? And that would be Sheri Belafsky, please.
Is Sheri?
Yes, please.
Sorry. So I think mythology is one of the biggest barriers that we're facing right now. And we have some interesting strategies for approaching that. So we've been collecting, with our partner organization, from directly from community members, some of the beliefs that they have about vaccines, or the potential harms that vaccines can have, that are circulating through their communities. And they've compiled, so this is Yolo County Children's Alliance, they've compiled a list of the mythology and then shared it with physicians, et cetera. And they're actually crafting right now a response to each one of those myths. And we're going to be able to then have like a formal response that we can provide to people with as much evidence or research to back it up. So I would say as a strategy for facing the mythology is information. And one of the things that's come up for me a lot too about our outreach efforts, even messaging, is I really can't underscore enough how I feel like we need to do so much more than just encourage people to get out and get vaccinated, but rather to be providing the detailed education, and not to underestimate, how curious and intelligent people are, and they really want scientific answers. They want true explanations.
Excellent. Thank you very much. Again, just being straightforward in this area, and that will really help break down barriers. And again, Veronica and Helidee, do you have suggestions, again, on what you see as those next issues that you've been seeing that may still be before us as we try to reach ever more individuals?
Can you repeat the question one more time? I'm sorry.
Of course. What type of additional challenges you may see before us that we have to take on, or turn that around, the strategies that you would like to reinforce as the most important to move forward, that you've already shown have worked so successfully at Livingston.
So for Livingston Community Health, our challenge continues to be those who do not want to be vaccinated. It doesn't matter if you bring the vaccine to them. It's just lack of information, or other reasons why they just don't want to be vaccinated. There's just not enough research for them. They just don't want it. So that continues to be a challenge for us, even when we're reaching out to populations, like we mentioned earlier during the presentation. When we do and meet with them, when we go out and meet one-on-one with them, the reason why we feel that that's a key is because they're able to disclose why they don't want it or the reason why they're not interested at the moment. And I think what's made it easy for us is being able to provide that medical staff. And like we said, a lot of it is misinformation. I think we mentioned it yesterday in yesterday's presentation. We have a lot of patients that have chronic diseases. They have issues with their heart. They're asthmatic. Their children are asthmatic. And for some reason, they feel if they get the vaccine, it's going to do some type of harm to them. So they don't want it. So a lot of it, like we mentioned, is going to be education. I think that's what's going to be key to get those that don't want to get vaccinated. You have to be able to provide something with information. You have to be able to provide medical staff. It's very hard to bring out doctors for mobile vaccination clinics, but I think a key would be something that would help support the efforts would be getting those physicians out there with us. I think, once our population has that one-on-one with the provider that they can't see or they're just scared and the provider's telling them, we recommend it. I think they will be more at ease of getting the vaccine. But like I mentioned, I believe the challenge will continue to be those that don't want it, and those who are just here for a short period of time. Um, uh, we've seen it and we continue to see it, even though we're doing as much as we can. But moving forward, I mean, the challenge is always going to be there. Our mission here at in this organization is to try to capture everyone and understand why. Um, like I said, I mean, we're still working every day trying to get as much as we can, but at the end of the day, it's going to be their option whether they want it or not. Our goal is to make sure that we make it as easy as possible for them to get vaccinated.
Wonderful. Thank you very much. And with that, I'd like to bring us to a close now. But yet, before we do that, give each of our panelists one more opportunity to share a parting suggestion, a takeaway as to what they have learned and their programs or organizations have learned in this very critical period of getting vaccinations to very high risk individuals, individuals that are very hard to reach, and see what they would recommend to you, particularly those who are looking at this going forward as to a key element to really make your program succeed. So I will ask our colleagues from Eskaton, then Livingston Community Health, and finally Healthy Davis together to give you a program, and then we'll bring today's session to a close. So again, if we could start, Darlene, what would be your takeaway from the experience that Eskaton has had in reaching homebound and older adults in different settings as to what organizations should tackle or how they can best approach this going forward?
Absolutely. I think what we have taken away as an organization is we are just more motivated than ever to serve older adults and provide access to resources that help them live well. And so as we rely on relationships with partnerships that bring so much expertise, we're able to do great things. And so continuing this effort of vaccines along with the other community outreach services that we provide we have just, I think, really grown in our understanding of how we can deliver our mission and really demonstrate that we care for older adults regardless of their age or their ability.
Thank you, Darlene. And for Helidee and Veronica, could you share a perspective from Livingston Community Health and how, again, reaching our vulnerable populations in rural settings?
Yes, thank you, David. So I will say that our takeaway from our experience is, and I know that I already mentioned this, but it's just if people are vaccine hesitant, they're going to be, and there's no easy access, they're going to be even more hesitant. So we want to make sure that we continue to decrease the barriers. I know that sometimes that means, for sometimes for the health centers or healthcare providers, it's easier to maybe bring, let's say, the Johnson and Johnson vaccine because it's a one dose. But if it's not really what people are expecting or their preferences, then this adds up as a barrier. So again, I would just say making it easy for them. Our events are from 20 to 40 people. I know it's not like the highest number, but we feel very proud of our work because those are 20, 40 individuals that did not have access to transportation. And therefore we went to them and they were able to get the vaccine. So just really making it easier for individuals to be able to get the vaccine if they're ready for the vaccine.
Wonderful. And Veronica, did you have anything to add to that?
No, I just want to echo what Helidee said. We will continue our efforts to try to reach to the most vulnerable. Like we mentioned, we will face challenges. We have barriers, but we have, other communities and other organizations that want to partner up to help us with our efforts. I just think it's really important to use all resources. Everybody, on this call, we know how important it is to collaborate with other organizations. Because it helps. It, it leads to helping just that person that does not want to be vaccinated, especially when you have multiple organizations all trying to reach out for the same cause. But like Helidee mentioned, we will continue our efforts, and we will do the best we can to make sure that we get to everybody. And it won't stop. It will continue. It'll be something that we will continue to take pride in the work we do. And like we mentioned, even if it's 20, if it's 40, if it's 1,000, it's 140, 1,000 that did not have a vaccine. So we're proud of the work we're doing, and we will continue our efforts.
Wonderful, Veronica. And Sheri Belafsky, if you would mind bringing us home with any of your final takeaways for our audience.
Thank you. I think a lot of what we've heard from my colleagues really stresses something that we're seeing and learning every day at Healthy Davis Together, that in order to be able to provide as many vaccines as we can and serve our vulnerable population in Yolo County, it requires a lot of flexibility. So if we can be open to new strategies and be willing to change, whether it's our hours or locations. I don't think back in February, I would have expected that we'd be going out into parks or going door to door. But I feel like being able to be flexible and not be attached to any one style of delivering vaccines is key for us. And I would say being responsive to the asks in the community, be ready to meet people where they are. It's a new one for us. And I'd also say to have an expectation that the process is going to be slower. We've moved out of a mass vaccine effort, and now we're really doing more high touch work. So to maybe approach it with an amount of patience.
Well, and that's a perfect way to end our session. I'd like to thank all of our panelists for their insights, for all the great work you've all been doing, to the organizations that have sponsored them, and again, to all the host organizations and partners that have been involved, and of course, to the supporters that have made these programs possible. Next slide, please. We would like to invite you to give us any input, information regarding the program that we've just provided. We also would like to share again that we will respond to any additional questions going forward. You can use the survey as you see here, just using the Menti program. And finally, like to share, if you go to the final slide, that all of our panelists are available to respond to you. We'd love to have you look into the wonderful work that Eskaton, Livingston Community Health, and Healthy Davis Together have been doing. Look at the Lighthouse, Activate, and Healthy Davis projects. They are truly innovative, doing amazing work. We're very little biased, but we're very proud to work with these colleagues, and you can learn more from each of their websites. And you can turn to the CITRIS website and CITRIS Health in our newsletter and website for any of these information on any of these programs. So with that, once again, thank our panelists. I thank you for joining us today, and we wish you a very good day. Thank you very much.
Thank you so much.
Thank you.
You.